Thank you so much for coming to this presentation about the Pride study and understanding lesbian, gay, bisexual, transgender, and queer health. We're going to introduce ourselves in a bit here, but first I wanted to get a little bit of information from you, from the audience. So this is Alumni Weekend. Thank you so much for being here. If we could get a show of hands, alumni from the School of Medicine, raise your hand. Couple, great, good. Okay, how about School of Nursing? Well represented, wow, okay, great. Pharmacy? Also well represented. Dentistry? One dentist left, okay. And graduate division? Couple graduate division folks as well? All right, great. Any others that I missed? Students, all right, excellent. Thank you for coming. All right, current student, great, wonderful. Do you want to introduce yourself and then I'll introduce myself? Sure.
Sure, hi. I'm Juno Obedin-Maliver. I'm an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Medicine. I'm also an alum. Oh, you can't hear? Hello? It's not on? Okay, I have to speak really close. Okay, sorry. I'm Juno Obedin-Maliver. I'm an assistant professor in the Department of Obstetrics, Gynecology, and Reproductive Sciences. I'm also the co-director of the Pride study with this guy over here, and an alum, residency class of 2014, and master's program 2016.
Great.
I'll be speaking a little bit later.
And I'm Mitchell Lunn. I'm an assistant professor in the Division of Nephrology in the Department of Medicine. I am an alum from the master's program in 2017, but did not do medicine, did not do my MD or residency or fellowship here. With that, we'd like to thank you for coming, and over the next hour and a half or so, hopefully be able to teach you a little bit about LGBT health and the work that we do. We designed this to be hopefully 45 minutes to an hour of a class without a quiz, and then have a lot of time for questions, which is really what we hope that this is beneficial for you. So a little bit, we usually start about our identities. Again, my name is Mitch. I'm a gay cisgender man, and we'll go through what some of those terms mean, and I use he, him, and his pronouns. Juno is a lesbian cisgender woman, and she uses she, her, and her pronouns. And so we'll talk a little bit about the importance of these going forward. But over the course of today, we hope that you'll come away with some important knowledge by today's session, and that you'll understand some of the causes of health and healthcare disparities that affect LGBTQ people, or more broadly, sexual and gender minorities. You'll be able to hear about some of the research that's gone on, as well as some of the data sources that exist that affect LGBTQ health. You'll hear a fair amount about the study that we conduct, the Pride study, as well as our community engagement arm, which we call PrideNet. And you'll get some results from that initial study so far. And then we hope that you'll be able to come away with ways that you can improve the care, and if you're a researcher, for caring for or researching LGBTQ people. And so we're going to kind of break that up into these 4 sections. And to start, neither of us have no financial or professional conflicts of interest that we need to disclose. We're funded by the National Institutes of Health, as well as the Patient-Centered Outcomes Research Institute, or PCORI. We will talk about a little bit of software development that was done by a company out of LA. And so to start, let's start with some healthcare disparities and really understanding how sexual and gender minority people are underserved by the healthcare system. They're understudied in research, and because of those things, they actually become vulnerable to poor health. And the first thing to really distinguish or delineate is this difference between sex and gender, because they oftentimes get conflated in society today. And so Juno's an OBGYN. She looks at ultrasounds like this, sonograms like this of a baby. And one of the things that a sonogram is for, oftentimes, is to obviously check to make sure the baby is healthy, and also to determine the sex of the baby, right? If Juno sees dangly bits between the legs of a baby there, she says that this is going to be a male baby, right? And so we oftentimes think of sex as the biological or physiological characteristics that define the phenotype, the way we look, right? And use terms typically as male or female. Where gender is really this socially constructed group of roles, behaviors, the way we look, that presents ourselves in a masculine way or a feminine way, and we typically use terms like man and woman to describe those. So we oftentimes say male and female are sex categories, and man and woman are gender terms, and we'll kind of use those throughout the presentation today. And these are, of course, different from sexuality, and we oftentimes think of sexuality as 3 different components, not just one. We think about how we identify. So I identify as a gay man. That's part of my identity. And that may be different from the people that I am attracted to, the genders of the people that I'm attracted to, and may be different from the people that I have sex with. And so the difference between attraction, behavior, and identity as all being an important component of sexuality. All of this is, rather complicated and hard to distinguish, so we use a couple of images that help. And this is the gender unicorn. He's kind of cute. I don't know if he's a he, but I haven't asked him his gender identity or which pronouns he uses. But there are really, these kind of 5 different components that are shown here. And so I'm going to do this on both sets of screens with a pointer because I don't think I can do it. You can't see this pointer there, can you? Nope. OK. So this little thought bubble of him is showing the gender identity of the unicorn, right? Whether he identifies as a man, as a woman, as neither gender, as something between genders, that sort of thing, right? Which is different from the gender expression. These green dots along the outside here, and again over here, which is how the gender unicorn presents the unicorn's self to society, right? Whether more in a masculine way or a feminine way, and that is different from the sex that the unicorn was assigned at birth, right? From the OBGYN or the pediatrician, which shows up on the birth certificate. And that may be different, and that is a completely separate concept from sexual attraction, romantic attraction, emotional attraction. So all of these can be different. And there's been studies of phenotypic, born people who are assigned male sex at birth have an identity as being straight, who are attracted to men and women, and primarily have sex with men, right? So showing that all of these are different components. This is confusing, but the easiest way that we remember this is that sex is what's between your genes, and that can be your genes like your pants or your DNA, right? And gender identity is what's between your ears. That's kind of an easy way to remember it. Another way to present this is the gender abacus. And so again, these are 4 different components: the anatomy, your gender identity, how you express yourself in the world, and who you're sexually or romantically attracted to. And again, each of these are independent items, right? These are 4 different rows, and the beads can be all the way to the left on one, all the way to the right in the other, half and half, a certain number on each side. And so these are really all fluid and on a continuum that exists. I think that many people have probably heard of LGBT, lesbian, gay, bisexual, and transgender. More and more people have probably heard of LGBTQ, that's adding the word queer, which is now, used to be a very, I think, offensive term, as people are nodding their head in the audience, and now that's really reclaimed, and people are embracing that term as an identity. But people may have also known that this alphabet, LGBTQ, it keeps adding more and more letters. LGBTQQIAA for queer, questioning, intersex, asexual, allies. Like it keeps on, so we joke that it's LGBTQ LMNOP, right? Because it just keeps on growing and growing and growing. And so academic medicine has created, this was all very confusing for people. Nobody could keep the letters straight. I can't half the time. I have to look them up. So we've now come up with this new term, not we, but academic medicine broadly has come up with this new term called sexual and gender minorities, or SGM. And this really refers to people who are not straight and who are not cisgender. And so we'll talk a little bit about that later. So those are people who are transgender as well as people who are not straight. And the question that we frequently get, Juno and I, is why is it even important to pay attention to LGBT people? How many of you are there actually in the country? I think in San Francisco, for those of you that live here, we know that there's lots of us, right? San Francisco does a city census. About 16% of San Francisco identifies as LGBT. But what about nationally? What does that actually look like? And so we know that from a variety of data sources here. And these are both federal governmental-run programs like the National Health Interview Survey, but also Gallup, the polling agency that calls you randomly and asks for your opinion on certain things. And so anywhere between 2 and 6% of the US population identifies as LGBT. And if we extrapolate that to the larger general, to the population of the United States, it's anywhere between probably 8 and 20 or 25 million people in the country identify as LGBT. So this is not a rare occurrence. And more recent data from Gallup shows that more and more people, or as time approaches, as time is getting closer to us, that now 4.1% of the population in 2016 compared to 3.5% in 2012 are identifying as LGBT. This is not that there's more LGBT people. This is that society has changed where people are now more comfortable to actually respond yes when Gallup gives them a phone call, right? And we also know on the bottom here that more of the millennials, more than 7% of them are identifying as LGBT compared to 1.4% of the traditionalists, people born between the ages, between 1913 and 1945. Again, more comfort with being out about their sexual orientation or gender identity. And when we think about health disparities that affect this population, it's really, I think, important to go back 50 or 60 years. And that was that homosexuality was a psychiatric diagnosis until 1973. When it was removed from the Diagnostic and Statistical Manual of Mental Disorders. Even today, gender dysphoria, which can be experienced by transgender people, is still a diagnosis in the DSM. In the mid-'80s and '90s, when we started to be able to identify genes and clone them and sequence them, there was the hunt for the gay gene and the trans gene in order to try to fix or repair the quote-unquote mutation. And in that same time, the 80s, 90s, and even into the 2000s, this concept of conversion therapy or talk therapy, oftentimes done by various religious organizations to kind of pray the gay away, right? And so has been outlawed in many states, but not everywhere. And we would be, of course, remiss to not talk about the HIV epidemic, especially here in San Francisco. People probably recognize these photos, very popular ones that have been shown over the decades. And the HIV epidemic really ravaged the LGBT community, among others. And when the LGBT community went for assistance to the medical community, to the research world, it was frankly met with hysteria. Doctors refused to care for them. Probably UCSF and San Francisco General Hospital is one exception to that, where it was actually a haven for people. But people not much older than me recall gay men being kicked out of their house and their families and literally dying on the sidewalks in the Castro, right, having nowhere to go. And so LGBT people for a long time have self-organized and have shown, kind of made their case for assistance in medical care and assistance in research. And that has really continued to grow over the past decades, and some of that I'll show today. I wanted to go through a few other healthcare disparities just to give you a quick snapshot of what things are like. And to do that, I'm going to show a couple videos, and this is the first video for kind of modern healthcare disparities, and HIV still remains, of course, as one of them.
Lesbians do it almost 3 times as much as straight women. Gay men do it nearly twice as much as straight men. And more than 400,000 people die from it every year. In fact, more people die from it than suicide, alcohol, car accidents, illegal drugs, and HIV combined. So, what is it? Smoking. It's time to speak up. We have to protect each other. To learn more, visit tobaccofreeca.com.
Now, we doubt that he stopped smoking right at that exact moment. He's now quit, right? If only it were that easy for people. But smoking and tobacco use really is a giant health burden for the LGBT community. We smoke 2/3 more than the straight population, so 1/5 of the general population smokes, and 1/3 of LGBT people smoke, spending now more than $8 billion a year, and cutting a significant number of years off of our lives. Some other important disparities: about 41% of transgender people have attempted suicide at some point in their life, compared to 1.6% of the general population. And of the homeless youth in this country, 40% of them identify as LGBT, and I think that's not overly surprising if you think about why they're homeless. They could be homeless because they got kicked out of their families based on their identity, or they left for their own safety, out of fear of their own, out of concerns of their own safety, staying in their house. We know in San Francisco that that's actually greater than 50% of the homeless youth in this country, and that's largely because people come to San Francisco because it's kind of known as a safe place for LGBT people. So people do definitely come here. Again, HIV still about 2/3 of the infections still occur among men who have sex with men, especially young men who have sex with men. Those disparities are compounded among transgender people, and even more among transgender people of color. And I think the challenge with these data is that transgender women, so that's somebody who was assigned male sex at birth and now identifies as a woman, are oftentimes aggregated together in studies among men who have sex with men. And so we actually don't know the HIV burden precisely among transgender people, among cisgender men. Kind of each of these groups are kind of all just bunched together, and that's part of the problem. Among sexual minority women, we have some data that intimate partner violence may actually be higher. And of course, those challenges differ, with about 44% of lesbian women and 61% of bisexual women having experienced intimate partner violence, compared to about 1/3 of straight women. And this is, of course, some challenges. Where do these people go? Oftentimes, they're not necessarily welcome at women's shelters. Basically reporting to the police or to other social service agencies may not necessarily understand the social structures or the experiences of sexual minority, that is, lesbian or bisexual women. And so there's oftentimes some safety concerns. Again, I'd like to show you another video. This one focuses on some of the health disparities that affect older adults that are LGBT.
As the American public ages, so do lesbian, gay, bisexual, and transgender people. LGBT older adults face the same challenges as other older adults, including financial worries and health concerns. But LGBT older adults face additional challenges. Let's compare 2 women, Tina and Jackie, who were both born in 1947. In 1967 at college, Tina meets Frank, and Jackie meets Francis. On a date with Francis after work, Jackie is seen by a coworker who tells their boss. Jackie is legally fired and takes a lesser-paying job at a factory. In 1973, Tina marries Frank, but Jackie is unable to marry Francis. In the 80s, Tina and Frank have children, but Jackie and Francis are barred from adopting. After decades of hard work, in 2010, Frank and Frances retire. Tina takes Social Security spousal benefits. But because the federal government didn't recognize same-sex marriages then, Jackie is denied those benefits. In 2015, right before the freedom to marry becomes available nationwide, Frank and Frances die. Tina pays for her in-home care with her Social Security survivor benefits and funds from Frank's pension. Jackie is denied Social Security survivor benefits, and because she was not a legal spouse, is also denied Frances's pension. Their apartment was rented in Frances's name, and her state lacks non-discrimination protections in housing, so Jackie is evicted when she tries to change the lease into her name. Lacking an income and a place to live, Jackie moves into a nursing home and relies on Medicaid to pay for it. She fears discrimination if she shares stories about her past, so she doesn't talk about her life with Frances. Tina can afford in-home nursing care and has the support of her children. After a lifetime of discrimination, LGBT older adults face economic insecurity, poorer health, and reduced support networks. Find out more about the unique disparities facing LGBT older adults and how to remedy them, as well as the strength and resilience of LGBT adults at lgbtmap.org/older adults.
So that's super depressing. I'm sorry, right? It's like over and over again. It's like a laundry list of things that really. But these are really true experiences for lots of people. So as depressing as they are, I think it's important to to recognize them. And this is a study from older adults, and we're not going to go through all these bars, but basically, the blue bars are LGBT people, the red bars are straight folk, and you can see that really for almost everything except for obesity in sexual minority men, LGBT people have more disability, obesity, asthma, and diabetes. So really affects all all throughout various organ systems here. But really, this is more than just about health and healthcare disparities. I've shown some documented healthcare disparities today, but the actual fact of the matter is that many of these come from small studies that occur in a particular city and are not based on any national data, and they're often limited in the way the studies are designed. They're oftentimes done in very convenient ways, recruiting people outside of bars or clubs or places that LGBT people may gather, community centers, those sorts of things. So they're not really representative. And because of this, there's really a whole slew, hundreds or thousands or millions of questions that remain unstudied about LGBT health. Some of those would be, what are the effects of hormones in transgender people on heart disease or cancer? What are the best breast cancer screening protocols, say for lesbian women who have never had kids, or for transgender men who have had mastectomies but still have some breast tissue there, right? These are things that we don't actually know. And there are a ton of barriers that remain to start answering these questions. And so we actually kind of view the cycle as this, that we don't really know that is at the top. We don't really know what the disparities are or don't have a detailed understanding of them. And healthcare providers end up not asking sexual orientation and gender identity. I think it's a pretty uncommon thing for people to ask. More and more it's happening. And there are now places in electronic health records for those types of questions to be properly recorded. But because we don't ask about sexual orientation and gender identity in a uniform way across the country in every primary care doctor's visit, we actually don't have a lot of data about the health of LGBT people. And because of that, these disparities end up persisting, and we end up not really being able to identify all of the disparities that exist. It's not just the healthcare providers that are to blame, quote unquote, for this problem, but there are really institutionalized or systemic discrimination. And we heard a little bit of that from the video about Tina and Jackie, the two older adults. But this is a map of employment discrimination in the United States. And I'm originally from Bismarck, North Dakota, which for those of you, nobody knows where North Dakota is. It's right here. It's in the middle somewhere, right? One of those square states. So right below Canada. But if That's right. Yeah, right. Not a great place to be gay. Precisely. And today, if I moved to North Dakota and was a practicing nephrologist there today, I could show up on Monday, because today's Friday, as if we never work on the weekends, right, Liz? So, and be fired from my job for being a gay man in North Dakota. Obviously, that's not the case in California, so all the darker colored states here have protections against being fired for sexual orientation and gender identity. There are a few states, Arkansas, Tennessee, and North Carolina, that have a yellow exclamation point, and those states actually have laws preventing the formation of non-discrimination laws. So they forbid non-discrimination laws. Just let that sink in for a second, right? Yeah, right. So, which is why, as state employees, we're actually not allowed to travel to certain states that are discriminatory towards the LGBT people, which is complicated. So, another map is health insurance, and this is a similar style map, which is that I could be denied health insurance coverage in North Dakota for being gay. Because they could chalk it up to my gayness and say that it's actually not covered. And so there's a variety of protections here. And you can see that are more states here with less protections. So these are just some examples of kind of institutionalized or systemic discrimination that is not uniform across the country. So what are the actual experiences of LGBT people as they enter the doctor's office? And this is a little bit of an old study. We're not going to go through each of these graphs, but this is showing that anywhere between about 4 and 20% of LGBT people have had some sort of negative experience in the doctor's office. And that includes things like the doctor or the healthcare provider refusing to touch them, blaming them for their health status, using abusive language, or actually even being physically abusive or doing inappropriate exams. And so you can imagine that people have negative experiences in the healthcare setting, and we know that about a half of LGBT people and nearly 90% of transgender people think that there's not enough healthcare providers who are adequately trained to care for them. So they've had poor experiences in the provider's office. They have to teach their provider how to take care of them. And of course, they never come back. Why would you go to a place where you're going to be discriminated against, right? And so people end up not seeking health care until very late stages of disease, even then, if at all. And so this has really turned people away. And this has also affected participation in research, right? Who conducts the research in this country on health? Well, it's the healthcare providers, right? And the healthcare systems and those. If you have negative experiences in one place, how do you have any trust or confidence that by participating in research that you're gonna have that same, you're gonna have any different of an experience? More recent data of more than 15,000 transgender people from the 2015 US Transgender Survey showed that the yellow bars or the orange bars here, about a third of people have had negative experiences from a healthcare provider in the past year, and about a quarter of them have chosen not to see a provider out of fear of mistreatment. And when we look at psychological distress that has severely interfered with your life in the past 30 days, on the left side here, about 2/3 of transgender folks have either said that they've had some or a lot of psychological distress that has interfered with their life. Compared to the general population, the National Health Interview Survey, about 1/3 has said a lot or some. So there's really striking differences here. When we look at insurance coverage, about a quarter of transgender people have been denied insurance coverage for their hormone therapy, so taking cross-sex hormones. Somebody born as a female sex assigned at birth taking testosterone, for example. And more than half have been denied gender-affirming surgeries. So say, for example, mastectomies for trans men. And when we look at insurance disparities broadly across the LGBT community, even today, in the Affordable Care Act era, in many states that have Medicaid expansion and some that don't, 15% of LGBT Americans remain uninsured compared to 7% of the general population. We know that that uninsurance rate is highest among transgender people, with a quarter of them being uninsured. And bisexual people are actually more likely, about 1 in 5 of them are uninsured compared to gay men and lesbian women. The Affordable Care Act has made drastic improvements in the insurance coverage for LGBT people, especially for those earning less than $45,000 a year, and has decreased the uninsurance rate significantly. And so as I wrap up my section, I wanted to also just talk a little bit about the invisibility. I've presented lots of data, which means that we've been able to find people, and people who study this have been able to find LGBT people. But the answer is that truly it's actually really hard to find them. I mentioned at the beginning of this talk that San Francisco does a city census to find LGBT people and see what zip codes and what areas of the city they live in. But the United States government does not. So the Census Bureau conducts a census every 10 years, and in the intervening years conducts the American Community Survey. And LGBT status, or sexual orientation and gender identity, is not collected in the census every year. So we have no idea where LGBT people live in this country. We don't know what their races and ethnicities are. We don't know how old they are. We don't know what religions they are. We don't know who they live with, those sorts of things. And it's only been in the past several years, 5 to 10 years, that sexual orientation and gender identity questions are starting to show up on federal health surveys, like the National Health Interview Survey, which is conducted by the CDC every year, or some people may be familiar with NHANES, the National Health and Nutrition Examination Survey. There's been a variety of cohort studies, the Nurses Health Study. Any Nurses Health Study participants in here, if you feel comfortable sharing your participation, right? Many people raising their hands. Thank you very much for participating in those things, right? Has asked sporadically, maybe once a decade, once every 2 decades, about sexual orientation. And probably one of the most famous cohort studies, the Framingham Heart Study in Massachusetts, has either never asked or asked one question at one point, and they're now in their 3rd or 4th generation of folks that are in that. And so as society has changed and people, again, the LGBT community has kind of come out forcing some activist and self-organization, the NIH started to get grant applications from many people at UCSF, for example, that were starting to study LGBT health. And the NIH was like, we don't know what we should fund. What's the agenda? What's the research agenda? What are the priorities? And so the NIH actually commissioned the Institute of Medicine, now called the National Academy of Medicine, to conduct a report on the health status of LGBT people, to give them a research agenda. The short answer is that everything was a gap. Everything needed to be funded, basically. There was such little. And this quote is what led to many, many changes, and why data is now starting to be collected in various places, including through the federal government. And that quote, I'm going to read it, is the relative lack of population-based data presents the greatest challenge to describing the health status and health-related needs of LGBT people. And that key part there is population-based data, right? Instead of the survey of people leaving a bar in the Castro, and we're extrapolating that to the life of LGBT people in Bismarck, North Dakota, right? And then finally, I think all of us were so excited when this designation came out in October of 2016, and this is Eliseo Perez-Estable, who was a UCSF faculty member and is now director of the National Institute of Minority Health and Health Disparities. And it was this designation that proclaimed sexual and gender minority people as a health disparity population for research. And people are like, I think all of us were like, well, yeah, but we've known that for a long time. But this was an outstanding, really, recognition of the fact that there are significant health and healthcare disparities that affect LGBT people. And this really opened the doors to a variety of now funding sources that are limited to health disparity populations. And it signaled a commitment from our nation's preeminent health research group, the National Institutes of Health, that this, it really signaled their commitment to starting to study LGBT health. And so that's what Juno and I now do for a living, in addition to to a little bit of our clinical roles. And so I'm going to turn it over to Juno, who will talk a little bit more about that. And I'll be back at the end to help with questions. Thank you.
Thank you so much. So we took all of that background, that experience of understanding the persistent and pervasive discrimination and stigma experienced by sexual and gender minority people. And it was our experience as clinicians, as educators. We kept giving lectures about LGBTQ or sexual and gender minority health and saying there isn't data here, there isn't data there. And we said, let's stop complaining and do something about it. And so this is our response to doing something about it, the PRIDE study. And it's a study I'll describe, but a key feature of it that we'll be talking about throughout is the role of the community in helping to inform the study at every step of the way. So the PRIDE study, every study has to have an acronym. We like PRIDE in and of itself, but it stands for Population Research in Identity and Disparities for Equality. And it's got a big central question, and we wanted it to be big to allow us to really investigate all the different ways that being identified as a sexual or gender minority person could influence your health. And we understand health to be big, the big picture health. So physical health, mental health, social health. What are people's lives and experiences as they walk through the world? And we have some guiding principles that helps us, as we try to answer these big questions. And one of the first really central one is that our participants know best. So I'm a researcher, I'm a clinician. I also happen to be part of the community. I'm also a gynecologist and an obstetrician, and so I really like understanding things like pregnancy or understanding about ovarian cancer, these types of things. But a lot of the community may not be interested in that. And the traditional approach of academics, right, is you say, well, I find this really interesting, let me go do some research on it. And we said we really need to flip that around and ask the community what they want us to study as a way of serving the community, saying we have the skills to do studies, what's important to you? And so we wanted to help ensure that our study at every step of the way recognized participants know best how to guide us. We wanted to similarly give back at every step of the way, make sure that what we have as the results of our study don't live and die in medical journals. And to do that, for it to be real and relevant for the community, we need to make sure that participants are involved in every step of the way so that we're not missing in how we're interpreting things, we're not out of scale in how we're shaping the findings that we have. To do this, in light of everything Mitch mentioned about discrimination, about people not coming to clinics, we need to make sure that our study is easily accessible. So just doing it in academic centers in San Francisco is not going to reach people all over the country. And we also don't want to put people out more than we need to. So our response was this design. It's a national online prospective longitudinal cohort, meaning that we're hoping to partner with people for decades. And it's dynamic, so people can come and keep enrolling over the course of the study. They could also go. We hope they don't. And we hope to follow people over time to understand how things are changing. To be included in the study, people need to self-identify as a sexual or gender minority. There's no real test for that. You just tell us. You need to be 18 or over, live in the United States. So participant status is not dependent on citizenship, and currently being comfortable reading and writing in English. We are looking to expand the study to lower ages and other languages, and that's in the future. So there are really two phases to our study. The first phase, we started it in 2015. And as I've mentioned a couple times now, we really wanted to make sure the community was involved. And so bringing together those principles of community involvement and engagement, we launched an iPhone app. And we used that app to really listen to community priorities about what they wanted us to study. So community-generated research questions and health priorities. That helped us think about and frame the next phase of the study, which I'll talk about. We also launched health surveys, pilot surveys, and all of that fed into the second phase of the study, which is where we're at now, which is the longitudinal data collection. And I'll talk more about that in a few minutes. Just want to point out our participant numbers because I think they're notable. So in our first phase, we had over 18,000 participants, which certainly makes this one of the larger studies that have ever been done of sexual and gender minority people. And phase 2, the longitudinal cohort, which we launched in May of 2017, so we're just the cusp of starting our second year of data collection, longitudinally has now over 11,200 people. The lift on the longitudinal data collection is a bit more, so we're still really excited about those numbers, and it's significant. So in terms of the study, people say, you know, how did we recruit this number of people? Many of the other studies you see in journals about LGBT people have a couple hundred maybe. I just reviewed an article that had 12 people. So, you know, interesting, but very different than thousands. And we are largely electronic, so I glossed over it, but, you know, we started with an app, and then our longitudinal cohort is entirely online. And so we use a lot of social media, mobile apps, and online advertisements to help find people so that we're not just limited to high LGBT concentrated areas. But the other key feature that we really take very seriously is that we partner with sexual and gender minority and health-focused organizations to really work with them to reach out to their constituents around the country. And we have many of them, which I'll show you some of our partners in a moment. We also reach out to healthcare providers for them to reach out to their patients and colleagues. So, excuse me, we recognize that we are not successful if we are only doing the PRIDE study, because the PRIDE study can only ask so many questions. And so part of what we want to do is change the culture around research involving sexual and gender minority people. Ultimately, we hope that every single study is involving assessments of people's sexual orientation and gender identity so that we can understand every aspect of people's health in relation to their sexual orientation and gender identity, as well as we might with other demographics such as race, age, religion, etc. And so we established what we call PrideNet. It's our community engagement arm, and it helps us operationalize how to engage people at every step of the process. And so we have this community partner consortium that keeps growing. Every time I talk to our community engagement team, they're like, oh, we have another great partner group. We're about 41 strong. And we also have a participant advisory board that helps advise us pretty much on everything that we do, as well as engagement activities and communication. So we do community listening sessions, webinars, these types of things around the country to help understand what people want from the study and also how we can give back to them and disseminate our findings. As part of our strategic values, we also have them for PrideNet. So we want to make sure that we're in give and take relationships with our community partners, that we recognize, although we're focused on people's sexual orientation and gender identities, people are not just those identities. So also, you know, understanding the complexity of people's lives in their communities. We want to make sure that as we are investigating and trying to advance people's health, that we're creating equity in all of our activities. So who participates in our webinars, who is not being reached by them, in our advisor groups, in our community partnerships. So we're really trying to make sure that who is at the table is representing the diversity that we ultimately want to reach. And we try to create transparency. So we are very frank about areas where we're not as strong and where we need help from our community partners. So these are some of our community partners. Very excited to be partnering with them. Some of them are organizations that might be familiar to you. So like the Human Rights Campaign, you may have seen this blue and yellow equal sign bumper sticker around. It's an organization with hundreds of chapters, I believe, thousands of employees, and a budget of millions of dollars. Some of our community partners have 3 volunteer staff. The same people who are writing the grants are plunging the toilets. So very different types of partnerships, and we customize how we are partnering with each of our partners depending on their capacity and what they feel like they can get from us and what we can give to them, et cetera. So these are clinics, advocacy organizations, health service organizations, and professional groups around the country. So we talked a little bit about our phase 1, our community listening pilot. And I want to talk for a moment about some of our findings. So we generated research questions and health priorities and health surveys, and I'll talk about that. So in our generation of and querying, no pun intended, or maybe every pun intended, of our community about what their research priorities were, we created this community forum where people could respond to the question, what do you care about? Post a topic that you would like researchers to study about the LGBTQ community. So that was the only thing that came from us. That was our prompt. And they responded with thousands of topics, more than we could ever complete in a lifetime. Really exciting things. So over 3,500 initial conversations and 5,000 replies. And then people could sort of upvote and downvote topics that they liked. There are obviously way too many for us to talk about here, but just a couple of them, which I think speak to how broadly our community is also thinking about health and what they want us to study. But right at the top were issues around depression and anxiety in the community, teen suicide, the role of family support in people's health as adults, violence among many different communities, but especially transgender women of color, the role of race and ethnicity in people's coming out, specific LGBTQ competency training for healthcare providers and how that has a ripple effect into people's health. And then this last one, which is always an incredible reminder to me of just what health means and how we influence health, which was high school sex education for LGBT students. So how people's experience in their educational environment as high schoolers was, down the line influencing people's own experience of their health, their life, their sexuality, what they're doing in terms of partnership and their lived experience. So we really, as clinicians, as providers, need to think about health broadly. And that's what our participants are challenging us to do. It's very exciting. And so now we'll switch gears into some of our health survey results. And these are just some of the pilot results. These are unadjusted proportional numbers, but they're still compelling. So overall, all of the different individuals in our community had some of these responses around their health conditions. So these were largely in response to a question of, have you ever been diagnosed with, or has a provider ever told you that you had one of these conditions on this road down here, okay? And then some of them around health experiences or behaviors. And so there are the numbers here, but then here in the green boxes are the national averages. And so you can see in our cohort, very high rates of asthma. So, why might that be? There's a lot of reasons for that. Obviously, that will take further study to delve into. But, Mitch showed that video about the higher rates of smoking among LGBTQ adults. And there's kind of history in that. So one experience maybe just gathering together in certain places like bars, or that this was sort of a socially sanctioned way to hang out and spend time together. But others is that tobacco companies actually had specific marketing campaigns to LGBT adults. So R.J. Reynolds' company actually had a campaign called Project Scum. Stood for Subculture Urban Marketing, and it was directed at the LGBTQ community, as well as homeless or marginally housed individuals in the Castro in San Francisco. And so, you know, it came out that that was how they were labeling this campaign, but they were not alone in doing that, and there's a lot of specific directed marketing that continues to this day to the community. And so does that ripple down into asthma, maybe cancer? We don't know, but those are one of the things that we think about. So, you know, some of these other considerations, there's a lot of backstories and more investigation that we would need to do to understand why all of these things are happening, but needless to say, we are seeing differences than the general population. Also, and not surprisingly, higher rates of you know, HIV testing, and that is in accordance with some national guidelines. But you know, this is still good to see how this is affecting individuals. Also very high rates of current smoking. When we take a look at mental health, we see similarly our cohorts proportions and then compared to national average. So, I mean, almost 58% reporting depression, high rates of anxiety, post-traumatic stress disorder. I mean, these are compelling numbers even without comparisons to national average, which we don't have up there, but we do down here. So ever having attempted suicide, 16%. It's just staggering and obviously way too high. Much more needs to be done to understand why that is, and then obviously to understand how we can intervene in meaningful ways. GAD-2 is anxiety screen, very high positive rates, as well as a screen for depression. Again, very high positive rates. We don't think that these are intrinsic to people's own identities, but more a reflection of this persistent stigma and discrimination and the systemic barriers that people have faced that Mitch talked about. In terms of what we call people's social health, so this is about people's lived experiences in their relationships, parenting, experiences around religion, we see that there are differences. Are these disparities? Not necessarily, but maybe they stem from some disparities. Maybe this is not where people would want them to be, or maybe this is just something that we need to understand better in terms of individualizing care for individuals. So, this is in terms of what we've done with our pilot study. We need to just talk about where we're at right now, which is that we recognize that our pilot, which was done on an iPhone app, wasn't going to reach everyone. Not everyone has an iPhone. Not everyone uses a smartphone at all or feels comfortable entering health data into a smartphone. And this is also a cautionary tale. Be careful what you tell reporters, because it can just show up and get tweeted around. I guess in this era, in this administration, we know the power of tweeting to move things. But Mitch was speaking to one of the reporters we've worked with before and said, you know, the Pride study is building a web version because reach of the iPhone isn't diverse enough. And so we wanted to make sure that we could reach people from any web-enabled device and not just an iPhone. So we launched phase 2 of our study, informed by many of the results from phase 1 that I talked about. This is the longitudinal data collection component. We launched it a year ago. We just had our birthday of the first point of data collection in this. And it's a custom web platform that we built from the ground up to really understand people and sort of their whole health. And we really modeled it after what we do as clinicians. And so we understand people's demographics, their past medical history, their surgical history. We collect medications. And then we ask people, using what we call our annual questionnaire, a whole host of questions that really span, we hope, much of the gamut of people's health. We also recognize that our annual questionnaire can't possibly actually delve into all of the depth that we want it to, and so we have other, what we call topic-specific studies or ancillary studies that help us go deeper into areas that we may not have been able to cover either at all or only summarily in the annual questionnaire. We have over 11,200 people so far on the longitudinal cohort. And just to give you a small flavor of what's in the annual questionnaire, physical health is covering things like cancer screening, sleep behaviors, activity levels, exercise, and my favorite, pregnancy and reproductive health. But including things like pregnancy and reproductive health among transgender men, or breastfeeding among transgender women. So these are individuals who are male sex assigned at birth and now are living their lives as the women that they are and yet want to breastfeed. Is that happening at all? We don't know. There's one case report out so far, only one in the published literature, but we're going to be assessing these things. Mental health. So again, we ask people's common diagnoses, but also ask about trauma broadly, experience, substance use, engagement with mental health providers, and then social health, people's experiences or not of religion, spirituality, both currently and growing up, parenting, whether they're parents or not, but also the experience in relationship to their own parents, employment, insurance, etc. So very broad cross-section. This is a little small for you, I think, but what we do on the study is what you might expect in, a paper, survey, research, if any of you participated in research at any point. We consent people and go through an eligibility module, and as part of our consent, we have a pledge. We talk about what we hope to do and give back to the community, as well as what we expect from participants. So we're trying to be transparent, as I mentioned before. What we think is really neat about our study is that we try to give people a sense of what's going on in real time with the cohort. So people, this is just a lot of boxes, but I'm going to talk you through this for a moment. When people log into their dashboard, so hi Mitch, welcome to your dashboard. You see the activities that you need. You've got a lot of activities. Can you get on that, please? Okay, so you're going to fill out your past medical history, your emergency contact information. Oh, you have an annual questionnaire. You have some other surveys. You're going to fill that out. And then you're also going to be able to see things like, and this is, you certainly can't see this. We have any optometrists in the room? This is a test. But you're going to be able to see how many people in the cohort are like you in terms of certain demographics. And so that's a neat thing in terms of sort of building this virtual community, and we're in this together. And we've heard from participants that people are really excited to give back and also to understand that they're not alone in this experience. The other thing that people can play with are each of these, trust me on this, it's really there, is that people, these are all drop-down boxes, and so people can select various demographics and health conditions and see how many people in real time on the cohort right now, how many people have certain conditions. And they can see that change every time they log in. It's my favorite thing to play with. Every day. Okay, so as a researcher. So one of the things I've mentioned a number of times is the role of community engagement. And this is not just lip service, and it takes a lot of energy, but we really think and believe that it's important. When I say that we do it at every step of the way, I just want to spend a moment of talking about what that actually means. So it means proposing the research questions, like we talked about in our pilot study. But then it also means reviewing research proposals and piloting studies, giving feedback. How are we asking questions? Does that feel comfortable? Does it not? How would you rather that we ask certain questions? Of course, it means participating in studies, but I will say that most studies, that's all that their community engagement means, and that's limited to us. and cutting off the brilliance of, and insights from the community. We also get feedback and solicit feedback once the survey is launched, because there are always blind spots for us. And so we understand and get feedback. We log all that feedback, categorize it, and try to respond. We respond to every single feedback, but we try to respond and make changes in response to all of that feedback. Of course, we as researchers review data results, but we also give raw data back to our community members and say, this is kind of what I'm seeing. Is this what you're seeing? Does that make sense as a story? Because there's always a story and an art to this. And that's part of refining analytical plans. So a lot of people say, gosh, how could the community understand chi-square tests? And you'd be surprised. Don't underestimate folks. If you explain it well, people give incredible feedback. And then planning how we disseminate back to the community, which is critical. And then repeating this cycle so that it's iterative. One of the things that has really come out of our community engagement is the incredible breadth of topics that we can't cover within our own research team, and our desire to catalyze research beyond just the studies and the questions that Mitch or I or the other main investigators of the study have. And so building on this collaborative spirit to support other academic researchers, especially given that there haven't been places, cohorts this large where people could understand the impact, understand the health correlations between sexual orientation, gender identity, and health. We have this ancillary study process. And so people apply to either analyze data that we already have, secondary data analyses, or disseminate new surveys to our cohort. And that goes through an extensive review process, both with a research advisory team, but also a community advisory panel. And that proposal is available if anybody's interested. And so some of our ancillary studies are things like the differences in sun protection behaviors, or the association of trauma and migraine. We showed earlier that the migraine rates were very high. We also know that the trauma rates are very high. What are the relationships in there when we can drill down more into that? And there are many others and more coming on the way. I think we have something like 10 in an active pipeline, and 15 others or so kind of starting to be developed. So it's very exciting stuff. So just to start to wrap this up, this is all connected. Discrimination leads to poor health. And I think you can understand how that plays out. And there are many ways that you can support pride. So there's the pride study. So certainly taking pride, participating if that's relevant for you, helping disseminate the opportunities for other people to participate and in the pride study, supporting the pride study, certainly financial, but time or energy, your insights and thoughts. But there's also, supporting the bigger vision of pride, right? So sexual and gender minority people having better clinical care. And so I'll just speak to that for a moment. There's a lot of great data and resources out there about how to make clinical spaces friendly. And as many clinicians in the room, I just want to give you a quick kind of rubric that I use, which is, when asking how you can signal approachability in your clinic, I want you to think about in your practice, what happens when patients come in the door to your practice? Are they asked in appropriate ways about their sexual orientation, about their gender identity, about their pronouns and names? Is that communicated between all of the staff? What happens behind closed doors? So meaning just between you and a patient in the exams that you're performing, when you're talking to them about their history and their lives. Mitch mentioned that a lot of people feel like discrimination is happening with their providers. Then what happens between closed doors? So you've been now here understanding and hearing this lecture for some time, you have an interest, but maybe somebody you're referring to doesn't have that experience, doesn't have a sensitivity of how to take care of people. So you want to think about when you refer people, are they similarly going to be taken care of sensitively with understanding about sexual and gender minority people's experiences? And then what happens to open the doors? So it's not just about, oh, we might have an LGBT person, sure, we'll kind of figure it out, but really thinking about welcoming the community in. What are the images that you're including as part of your solicitation and to the community and talking about your services? So some of the things to think about is how you ask and where you ask about sexual orientation and gender identity. There are different thoughts on that, whether it's an initial visit, follow-up visits, an intake, pre-appointment questionnaires, many different ways to do that. And part of this is customizing your care to meet your individual patient. So asking things like, should I include it in your medical record or not? Most patients do want to be asked. That's been well studied, but not all. And so thinking about how you include it and can you ensure confidentiality? What if the medical record is sent to another facility? There are many points of contact about asking about people's sexual orientation and gender identity. That will need to be customized to your system, but I challenge you to think about how you can do that. And then you want to think about how to ask. So there's no one correct way to ask. I only provide examples here. So the biggest one is not to make assumptions. So if someone walks in, and they appear a particular way, doesn't mean that they are straight or not straight or have a particular sexual orientation or gender identity. So you want to think about special considerations like setting, acuity, age, condition. All of these factors may influence things. And some people say, gosh, I work in the ICU or I work on labor and delivery and somebody's showing up about to deliver a baby, that's not the time to ask. But I challenge you to say, well, if somebody is about to unfortunately pass away in the ICU, you need to know who that person's significant other is or how they want to be referred to or who's going to be there if something unfortunate happens in the course of the delivery, for example. So some quick primers on how to ask about gender identity first. So this is just language that we use that can be helpful. I also talk to my patients about gender identity. Do you know what I mean by that? So the idea would be there's something before this and something after. But some people may feel like their physical bodies don't match the gender they most identify with. Knowing your gender identity will also allow me to care for you. So, a lot of people will, because the majority of people are cisgender, meaning that their sex assigned at birth matches with their current gender identity, but some people aren't. And so you want to ask everybody routinely. And I've been surprised that I've had 70-year-olds at the VA suddenly come out to me and said, I've never been asked that before. You want to ask about pronouns. So don't assume that somebody uses she or her or he or him just because somebody has certain facial features, the clothes they wear, etc. And then again, asking if it's okay to document. We want to use gender-neutral language. So instead of saying to somebody who's presenting as a woman, or even if they acknowledge that they are a woman, not assuming that they have a husband or a boyfriend. Things like, do you have a partner or significant other? Are you in an intimate or sexual relationship? Somebody else is in the room. Who is this person? How are they related to you? How would you like me to refer to them? Those kinds of things. So practicing these questions can be helpful. This is another one around sexual orientation. Like the questions I ask about tobacco, alcohol, and other drugs, I'd like to ask some more questions that I ask of all my patients, and make sure you do that. These are the ones about your sexual activity, your sexual health, and identity. So are you sexually active? Well, what does that mean? So you kind of want to drill down. What does that really mean for people thinking about organs and what's actually going where based on people's anatomy, if that's relevant. And then, I was taught in medical school, are your partners men, women, or both? I think that's limited because we know that there's more than two genders. And so rather, the new terminology coming out is really what genders are your partners, and letting people speak to that. Knowing about your sexuality will help me better care for you if people are saying, why are you asking these questions? And it may not be relevant if someone comes in for a rash to urgent care, in that moment, but it really may be if you're starting a primary care relationship with someone. So, of course, just leaving things open at the end to ask. There are some really good resources out there. So this one by our colleagues at the Fenway Institute in Boston really takes you through systematically. There's a webinar associated, but this is sort of their top 10 list of things to do on your checklist to make sure that your practice, clinical space, is SGM friendly. And we certainly have not gone through all of them or really any of them in great depth, but the biggest ones that we have touched on are some processes that reflect why certain processes and forms would need to reflect the diversity of LGBT people in their relationships, data that are or are not collected in sexual orientation and gender identity in a clinical space, and we've certainly talked about that in research. And really ensuring that all patients are receiving routine sexual histories, but I would really implore you to think, sexual and gender minority health is really not just about sexual histories, and it's too long been relegated there. So thinking about, the broad conception of health that we've taken on in the study also applies to people's lived experiences and certainly their health. There's obviously many other features, but this hour-long webinar from the Fenway Institute will take you a long way. So some of these takeaway messages, sexual and gender minority individuals are underserved in terms of their healthcare needs, understudied in terms of research, and therefore vulnerable to poor health. There are notable health and healthcare inequities. There's also probably a lot of resilience. Not every sexual and gender minority person is experiencing terrible health. And so we want to also understand why, in the face of all of these systemic inequities, some people are really thriving and just really helping change the face of our understanding about the diversity of life and how it's lived. So there's also positive notes there too. We want to think about really ensuring community engagement in all parts of research and how that process fosters positive researcher community relationships and really expands our understanding of health in deeper ways than what we've done in previous generations of research. We at the Pride Study and PrideNet are using technology to engage researchers and sexual and gender minority communities, but it's really focused, and the linchpin of all of this are ongoing relationships. And there are numerous ways and changes that you can make in your practice to be more welcoming to sexual and gender minority people and really support whole health of individuals and this community at large. We have some water up here for you too. Here. Oh, you have some, okay. So obviously this extensive work could not be done without a team. We have incredible individuals and partnerships that make this possible. I couldn't acknowledge everyone here, but these are some of the great people. We also were really indebted to our funders, also certainly to UCSF that has been the place that we birthed this, gestated and birthed. Again, I'm the OBGYN, right? This study, and as well as the NIH San Francisco General Foundation that hosts some of our projects now. And then we've had a lot of really generous support from some pro bono developers. So thank you so much for your kind attention. I think we have a little bit of time for questions. These are our email addresses. Please check out our website, and thank you again. I guess we sit here now.
Yeah, so I think we're happy to take questions on anything. No question is silly or too big or too small. We've given you a ton of information in a very short amount of time, so we're here to help. I think there's a question over there, and then here. I think there's a microphone coming right behind you. Let's knock up on you.
I'm embarrassed to say, can you hear me?
Yeah.
I'm embarrassed to say that when I see someone's morphology and then ask about the pronouns, if there's a discrepancy, it doesn't sink in to me. It's hard. Of course, once you really know the person, you understand them. But just do you have any way to? I guess just letting it sink in and inquiring and interacting with the person enough to really sense that they are that gender. It just, for me, it's a little bit tricky.
Yeah, and I want to acknowledge, I think that that's normal. You know, this is how our language is constructed. I have a 16-month-old, and I think about this every time, you know, do I point out and say, gosh, that's a boy or that's a girl on the playground, right? It starts very early on, and I want him to understand our English language. But, you know, it's a normal patterning that we've been given, but it's a cultural pattern, and we really do want to, you know, acknowledge people's internal experience that may be different. So I think practice is really important, and I would, you know, encourage you to practice in your own time and space and with friends and colleagues rather than, you know, with patients. But I think just acknowledging that, and I think part of that too is being humble. You know, I make mistakes all the time, and I have, you know, slipped on pronouns even with good friends or colleagues of mine, and I just say, I'm really sorry. I made a mistake there, and that was inappropriate. I think it's also really important then, as you're doing that internal work, which is so needed and so grateful, and thank you for, you know, just acknowledging that internal struggle, is then also, you know, being an ally is not, you know, needing that person to always do that, but, you know, taking up that space. So if other people are misgendering or mispronouncing people, now you can, you know, be an advocate for them, and it helps decrease the burden for others. And that's very welcome.
Yeah, I mean, we had somebody on our team, you know, for a summer who was assigned female sex at birth, and I think it gets even harder for people when their pronouns that they use are they, them, and their, right? So using kind of a plural pronoun to describe a single person is a hard thing just by the way that we've all grown up, right? You know, so instead of saying she's going to the store, it's, you know, they're going to the store today, and you're talking about a single person, right? And so and I made mistakes, you know, frequently. And again, the idea of apologizing and, you know, and I think just by even showing that you're cognizant of the mistake that you've made is, you know, leaps and bounds ahead of others. So question over here, then we'll go over here. So.
Hi, thank you for your talk. It was really informative. I know the study's ongoing, but did you get a good geographic distribution in your participants' responses? And did you find anything different geographically in their concerns when you were forming the study and the risks that they identified in the results coming in?
Yeah, so I can talk a little bit about some of these. So, you know, in the longitudinal phase 2, that started in May of 2017, we collect a zip code on everyone, so we know where they're from, and the regions. So we have region from all over the country. The West region is the largest. The second, so this is the U.S. Census regions, of which there are 4. So it's West, which is basically like everything from Colorado, from like the Rockies west, like everything. It's a giant part of you know, land mass. Second largest represented region is the South, actually. The South is, nobody ever includes this, but the South is Delaware through Texas. So anytime anybody ever thinks that Delaware is in the South, let me know, right? You know, it's a very interesting the way that the Census Bureau divides it up. So it's also a huge amount of landmass, right? It's the true deep South. It is the Southeast, and it is also a fair part of mid-Atlantic states also fall into the southern region. So, but you know, we are pretty equal, a little heavier weighted towards the West region, but but of all 4 regions, the Midwest and the Northeast. So, and then we have not yet looked at differences really by region. At least in any kind of data analytic way. We do not infrequently get concerns that are voiced to us by email, or we have an 800 number or so by telephone call, of people's concern about their participation and whether or not they will be outed, and just how we keep people's data and identity safe and secure, especially in the era of Democratic National Committee hacking in Russia and everybody being all concerned about databases, right? It's become a new thing. And so I think, and those are largely people coming from areas that we assume to be less, less supportive. So rural areas, some areas in the Deep South, and especially for people that have various intersecting identities. So you're a transgender person, you're also a racial or ethnic minority, and you may also have a lower socioeconomic status. And so all of, you can imagine that having some extra discrimination may affect your ability to get healthcare coverage or other things. And so people can be very reluctant and try to test the waters out with us ahead of time. I don't know if there's anything from the community forum that was regional based.
People expressed that actually as a question. They wanted to understand regional differences. And we know from other data that regions and local policies matter. So prior to marriage equality being the law of the land, we saw in states that where marriage was legal, that there were actually lower incidences of, or lower prevalence, of mental health diagnoses. And so, these policies were really, really tied to people's experiences. And so we will be looking at things like that when we have sort of more aggregate data and numbers to do regional analyses.
Sure.
I just want to hear your thoughts about this case. I know someone who had a sex change from male to female, but I still have a difficulty switching from he to she. But I know that he submitted a petition to the Supreme Court of the country of origin to change all the documentations from male, so I guess from male to female, and it was denied. So do you have any position about that?
It's difficult. I mean, the experience of, so I think you're talking about a transgender woman, but transgender individuals around the world, that is a very common experience, unfortunately. Many countries around the world, there's many barriers to changing documentation, and documentation is really, your passport, but the way that you move through society. So a driver's license, your passport, how you get insurance, all of those things. If there's a discrepancy between your documentation, your identity documents, or access documents like insurance, it can be very hard to do many other things like get employment, get healthcare, participate in civic activities like voting and stuff. And so I think this is where we as health professionals actually need to be involved in policy, because what we know is that in areas where it's more challenging to have your identity acknowledged, so this person's lived reality sounds like is not being acknowledged by governmental systems, people are more prone to poor health and lower employment rates, worse health care, and many health sequelae. And so I think that we need to stand up and speak to those governmental systems and these systems to try to help change that in the interest of health, but also in the interest of human rights.
And I think, in the United States, these are actually very on a state by state and in some cases city by city basis for changing, gender markers on documents, right? So you can go to the DMV and, there's a policy / process there to change, your driver's license in California, for example, but that is different in North Dakota. Right? And so you can imagine that there are times where people's documents are incongruent with each other, right? And so you may be a trans man, so born with female sex assigned at birth, and you've now changed your gender marker on your driver's license and on your insurance card. And so now, and then your insurance claim gets denied because the insurance is denying a pap smear on somebody with a gender marker as male, right? And so they still have a cervix, they still need some cancer screening, and so there's lots of issues that can happen, right? Because just because certain policies and systems in society have changed, it doesn't necessarily mean that the insurance company has changed, or that the biller has changed, or the payer has changed, or those sorts of things.
So California was just recently, in California, Medicare, Medicaid services made the change that gender is not, let's see, that pregnancy-related services are not dependent on gender. So as a man, you can get coverage for your pregnancy. And just to say explicitly, because not all transgender individuals undergo what we call gender-affirming procedures or take hormones. So, somebody's gender identity doesn't necessarily mean that they will have particular surgeries or use certain medications. And so transgender men may get pregnant or still have a cervix and need cancer screening. And so now, at least in California, and it's one of the first states in the country to do so, gender is not a prerequisite for getting prenatal care. That's an important step forward that took a lot of advocacy.
Yeah, I think it's good actually to talk a little bit about the kind of different types of transition, which we didn't talk about. So there's, social transition, which is, maybe changing your name, maybe changing the way your gender expression, the clothes you wear, those sorts of things, pronouns. Another option is medical transition, so taking cross-sex hormones. And then surgical, having gender-affirming surgeries or procedures. And people can do all or none of these, right? It's mix and match
good
menu of options. Yeah. Oh, yeah. Sorry. Here and then here.
Yeah.
So
Thank you, Donahue.
Yeah, exactly.
Adult geriatric nurse practitioner 2014. Thank you so much for this incredible presentation, the work that you're doing. Quick question. I was really pleased to see in the ancillary projects that there are older adults looking at health and physical and mental health of this. Could you give us a sense of what is the sort of distribution of ages? And really curious.
Sure.
Obviously, the needs for older adults in this population, I would suspect, are quite different.
Sure, I'll start.
Sure, yeah.
So our median age in the cohort right now is about 29. Certainly we start, at 18 right now and go up to
80 something.
Or something,
Is the range, right?
Is the range. But I think, sort of 90, at least 90% right now are under 55 or so. And that's, the last time we ran that was a little bit ago. We recognize that, and so that's, we think, a limitation, and it's not the distribution that we fully want. And so we've partnered, one of our community partners, which is called SAGE, they specifically focus on the experiences of LGBT and sexual and gender minority elders and aging. And so not just people who are currently above a certain age, but just also what is the experience of aging in this country. And so we've been actively working with them and thinking through with them, both in our materials, but also, for example, how we can expand, even though we're an online study, having phone available, having potentially paper available. How do we do these things to really be multimodal in a way that meets people where they're at? And so these are the kinds of things that we're thinking about, and that's how we use our community partners to really say, gosh, we have a gap here. How do we change this? How do we meet what that community needs?
Yeah, I think we have unique challenges being a digital-only study compared to, say, a multi-site thing, right? There are also numerous benefits. It is a heck of a lot cheaper to have a digital study than 20 sites with staff members across the country at each of them, right? That is a tens of millions of dollar project, right, to do that. So if any of you want to start that, feel free to see us after, and we'll, but I think that there's really, those are some of the pros and cons that we've gone through. And so we're looking at other, there are senior centers, there are computer centers, are there ambassadors that can be kind of study liaisons that can be at each of those places to help older adults who may be a little less tech savvy at completing things, right? You know, I think the actuality, people, you know, have, you know, several years ago, people were like, you know, older adults don't use technology at all. That is not true. I think we know very clearly that internet connectivity and smartphone and tablet use among older adults is growing just like it is amongst, and in some cases greater than the general population, right? So people are using all of those devices. It's just a matter of people's comfort level in sharing sensitive information that way. So.
And that they're unique opportunities. So I really see this as a potential, for example, for connectivity, or thinking about, you know, potentially combating isolation. You know, how do we think about the community that we're creating, and how do we support those unique questions in different populations? So the questions that we might be eventually, you know, asking very specifically of our younger part of our cohort are going to be different, and that's really profound and beautiful to think about how we can learn different things from different generations within our study.
I had a question. Is it on?
I think so.
Okay. I had a question about your reaching out to your partner organizations.
Yeah.
My son is a main site manager at Callan Lord
Oh, nice.
in New York.
Yeah.
He has become very disillusioned with the organization because he feels the organization itself is really now only out for money, only out to bring in grants, and that the true mission of Callan Lord and how the employees are selected and how the employees behave is being lost. So.
Makes me sad to hear that.
Yeah, absolutely.
Because so for people who don't know, Callan Lord is a community center in Manhattan. They now have a couple clinics. I think they have one in Brooklyn and a couple in other places that primarily serve a very large LGBT population. So similar to maybe Lion Martin Health Services in San Francisco, for those who are familiar with it. Howard Brown in Chicago. There's several of these kind of LGBT-focused places
And
across the
a
country.
big focus, the majority of their patients are street people, and the majority now are transgender.
Right, lots of
Yeah.
marginally housed or homeless
Yeah.
transgender folks, right? So, you know, the way our group at least interacts with these organizations is we have several staff members that were on that page of photos who are in charge of community engagement, and so there, with Juno mentioned that we now have 41 community partners across the country. Some of them are larger systems like Callan Lord's, and we have a liaison or two at each of those places, and so they're ones that can help us do engagement of the Callan Lord patient population, but also certain times we need on the ground provider opinions of things, right? I'm a nephrologist. I do dialysis with Liz. And Juno's an OBGYN. We don't have a primary care LGBT practice, right? I have LGBT people that I take care of. So does Juno. But we don't have. Sometimes we need the perspective of somebody who is literally on the front lines every single day, right? And so. Our team works to maintain those relationships. Our team knows when, Joe at Callan Lord is going on vacation because we really try to build these bi-directional relationships that are meaningful. And it's not just us as a big academic medical center using, and I'm using that word correctly here, using a community-based clinic for their people. Right, we're trying to help them fulfill their missions of participating in research and advancing health, while also, getting the advice and expertise that we need.
Yeah.
That said, when I was at Columbia,
Yeah.
we had someone who wanted to transition.
Yeah.
We always sent them
To
to Callan.
Callan Lord.
Yeah.
No, and they, and a lot of these places have become, and rightfully so, decades of experience and have become the expert and have really defined the policies and procedures for getting things done, right? In the midst of a system that can be discriminatory and challenging to deal with. Yeah.
Hi there. My name's Liam. I actually work at a community health center here in San Francisco.
Very cool.
And my question is around exactly what you were just talking about. What do you do when, like at my health center, we do serve primarily the transgender community and the LGBT community at large? Is there anything that the study can do to help us do a better job? Because even though we do a very good job, and I can speak to that as a transgender person, but we always have ways in which we need to improve. And one of the things, I do see gaps because we don't have any transgender specifically identified providers. And there are always going to be gaps there where there are little misunderstandings and little things.
Absolutely.
I don't want to be embarrassed for my health clinic, but if we were involved in something like that, I'm just wondering what you could do to help us move forward.
Well, part of our job is to try to catalyze better health, and part of that is through information. So there's different types of health research, obviously. So there's kind of health services research, so that might happen, in a clinic setting to do quality improvement or improve how things are delivered on the ground. And then there's sort of what we're doing in national survey data. And so feeding that back, what we hope to do and are just starting to do now with initial data is feeding that back to our partners and the general population to say this is what we're seeing. So we're seeing, very high rates of asthma. Gosh, are you really thinking about this? Are you asking about this? And if you're seeing it and we're seeing it, are there certain interventions or campaigns that would make sense? Like, how could we think about, asthma campaigns that really would touch and would be meaningful to the LGBTQ plus community, which is different than just saying, here's, some statistics, go run with it. So that's where our partnerships come up, and we hope that through our ancillary studies and through people using our surveys, they can start to ask these questions of like, well, gosh, we are seeing high rates of smoking or, asthma, so what? And then it's the so what? Like, what do we do with that to improve healthcare? And so part of that is informed by, what does it mean on the ground to you in your clinic? So when you say, we could be doing a better job, I would want to know, what do you mean by that? Like, what are you seeing? And is there something that we can ask about in our surveys on a national level that would then feed back to you and say, you're not the only one. You're seeing it in San Francisco, they're seeing it in Chicago, they're seeing it in Bismarck, and it's slightly different. And is there something interesting in those differences that can help us, is someplace less, someplace more, and gosh, this place is, doing XYZ thing different. How can we change practices? So that's, a very big, a little bit amorphous response, but that's the idea of, the data that we're trying to give back and generate through our relationships. That's, I think our community partners are dedicated to that vision of us trying to cycle through iterations of they tell us what they see and what they want us to ask, and we try to give things back to them.
It is 12:10, I assume.
Oh my
and
gosh.
we are getting the signal in the back to wrap it up.
Wow.
So we'll stick around after if there's any questions that people want to come up. Thank you so much for coming. Really appreciate it.